Webinar is going.
We're just going to let people join the session and then we'll get started in a few moments. All right, so I think we'll get started. So I just want to welcome everyone to this session today titled Brain and Behavior by the Alzheimer's Society of Sudbury, Manitoulin, North Bay and Districts. So my name's Taylor. I am a community health promoter at the North Bay Parry Sound District Health Unit, and my pronouns are she, her. Before we begin, I'm just going to go over some housekeeping items. So if anyone has any issues, like technology issues or issues with the Zoom platform, please feel free to type in the chat at the bottom of your screen, and my colleague Kelsey is in the background helping to assist with any issues that anyone has. If you have any questions for our presenter Ava today, please feel free to use the Q&A option or the chat, whichever you feel most comfortable with, and she'll answer questions at the end of the session. If you want to ask her a question, not in chat, but verbally, you can raise your hand and we can unmute you at the end of the question or at the end of the session and ask your question. The session is being recorded and it will be made available on the Health Unit website at a later date. We apologize as right now we're having issues with our closed caption option, so we aren't able to offer that at this time. We are working with Zoom to try and have that available for future webinars. But before we get started, I just want to acknowledge that we are hosting today's meeting on land that has been inhabited by the Indigenous people since time immemorial. The North Bay Parry Sound District Health Unit sits on the traditional territory of the Anishwabic people and within the lands protected by the Robinson Huron Treaty of 1850. Used by members of Nipissing First Nation. We acknowledge that we are also situated on unceded territory of the Algonquin Nation and settlement of the Métis Nation. As individuals and as organizations, we are dedicated to honoring the Indigenous culture and history and committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. So this session today is being presented by Ava Keys, with the Alzheimer's Society. Some of you may have been on her session yesterday, which apparently went very, very well. So Ava is a public education and health promotion facilitator with the Sudbury, Manitoulin, North Bay and Districts Alzheimer's Society, and she's based out of the North Bay office. She offers education and training for the community's general public, healthcare providers, first responders, care partners, family members, and for those living with Alzheimer's disease and related dementias. So I think today we'll just start with a quick introductory poll just to see who's in the audience, and then we'll let Ava take it away. So you'll see a poll come up. There's one question just asking how people identify, so you can select all that apply to you. We'll just give you a few moments and then Kelsey will end the poll and we'll get to check out the results.
Quick this morning.
Oh, that's
sitting at 75%. I'll give it a couple more seconds here.
perfect.
Okay, thanks for participating. I'll end the poll and I'll share our results. Here we are.
Perfect. So we have 100% of our participants are over the age of 55. We have one participant that's identifies as francophone and one that's a caregiver or family member of someone 55 and over. So great. We welcome all of you. And without further ado, I'm going to pass it over to Ava.
Thank you so much for the introduction. Yes, so my name is Ava Keys. As Taylor mentioned, I am the Public Education and Health Promotion Facilitator here at the North Bay Alzheimer's Society. Today, I'm going to be presenting to you our Introduction to Brain and Behavior presentation. By the end of this presentation, you will have received an introduction to dementia, how the brain becomes impacted by dementia, common responsive behaviors presented by people living with dementia, as well as strategies for responding to these. For those of you who participated in the presentation yesterday, some of this information may be a brief overview, but we will end up focusing more on how the brain is impacted. So again, feel free to reserve your questions for the end of this presentation. Because it's a bit more extensive, I would like to save the questions for the end so that we have enough time to cover all of the material. If I don't have an answer for you right away, I will get that information and get back to you. So we're going to begin with a basic overview of dementia. So dementia is an umbrella term that describes a wide range of symptoms that are caused by disorders affecting the brain. Almost 40% of people over the age of 65 are going to experience some form of age-associated memory impairment. However, dementia is not a part of this normal aging. People living with dementia are going to experience memory loss that is severe enough to the point where difficulties with thinking, problem solving, and language will reduce the individual's ability to perform everyday activities and carry out a normal routine. They will also experience short and long-term memory loss, difficulty with both learning new things and completing familiar tasks, as well as experience changes in mood, behavior, and personality characteristics. There are actually over 100 different types of dementia. I'm going to give a brief overview of the most common top 4. And as this presentation goes on, you can think of dementia like the term cancer. It is a classification that determines the symptoms that the person living with dementia may experience, as well as treatment options, etc. So first, we're going to go over Alzheimer's disease. It is the most popular form of dementia, hence why we call ourselves the Alzheimer's Society. It makes up about 60 to 80% of cases and is characterized by slow declining effects that typically last anywhere from 8 to 10 years from the early stages to the end of life stage. The decline is present in all aspects of a person's life, including how they think, feel, and act, and it progresses like a slope. It is consistent and gradual. Each person is going to be affected differently, and but there are some warning signs that you can watch for. So their cognitive and functional abilities, including the ability to understand, think, remember, and communicate, will impact the person's ability to make decisions, perform what used to be simple tasks, or follow a conversation. They may lose their way, experience confusion, and initially, this happens only for recent events in the early stages, but eventually long-term memory will be impacted as the dementia progresses. Their emotions and moods are often expressed through a loss of interest, with them seeming less expressive or withdrawn. Their physical abilities are going to be affected by means of coordination and mobility to the point that performing day-to-day tasks are going to be difficult. And behavior changes often include reactions that seem out of character And that is what we will be focusing on later in this presentation. And then we have vascular dementia. This is the second most common type of dementia, and it makes up for about 20% of cases. And the onset of vascular dementia is when the vascular system fails to provide enough blood to the brain, causing cells to become deprived of oxygen and eventually terminate. This dementia can be caused by stroke. However, having a stroke does not mean that you will develop dementia. It just means that you are at a higher risk of this vascular dementia. The same can be said about brain hemorrhages or concussions. It all just depends on the brain's ability to recover. Progression of vascular dementia is different than other types of dementia because it can last anywhere for 3 to 30 years because of its progression. It progresses like a staircase where symptoms deteriorate rapidly and then remain stable for a period of time before rapidly declining again. Typical symptoms developed in vascular dementia include changes in ability to make decisions, plan or organize, and difficulties with movement, such as slow gait and poor balance. Third, we have Lewy body dementia, and this form of dementia makes up 5 to 15% of people living with dementia. It occurs when abnormal protein deposits called Lewy bodies develop inside the brain's nerve cells. And what happens is they build up and block messages between the brain cells in areas that regulate behavior, cognition, and movement. Symptoms in Lewy body dementia will mimic Parkinson's disease, such as tremors, body stiffness, and shuffling of the feet. And those with Parkinson's disease are at greater risk of developing Lewy body dementia. These individuals will also experience a progressive loss of memory, language, and reasoning, and may see an onset of depression or anxiety. And they are most likely, out of all forms of dementia, to suffer from visual spatial disorientation, including hallucinations and paranoia. So visual hallucinations are common and can be worse during times of increased confusion, and they often consist of people, children, or animals. And they may also experience psychotic and fixed false beliefs, otherwise known as paranoia. So for example, seeing faces in a carpet pattern, or believing that somebody has stolen one of your possessions, despite the fact that it has actually just been misplaced. Lastly, we're going to cover frontotemporal dementia. This is responsible from 2 to 5% of dementia cases and primarily affects the frontal and the temporal regions of the brain. The frontal lobe regulates critical judgment and thinking and is considered the filter of the brain. And the temporal lobe is responsible for regulating language and communication. So unlike Alzheimer's disease, these individuals living with frontotemporal dementia are going to experience significant behavioral and personality changes first. This is because they experience that loss of filter, and so they may say inappropriate things or do things out of character. These changes in behavior and communication abilities often make this the most difficult type of dementia for family members and caregivers of this individual. We also see mixed dementia. This is exactly as it sounds. Some people may be living with more than one form of dementia at a time. And there's also dementia referred to as young onset dementia. And this makes up anywhere from 2 to 8% of dementia cases, and it progresses at a much quicker rate of about 6 years. Young onset dementia refers to anyone living with dementia under the age of 65, and it can apply to all types of dementia. So for example, young onset Alzheimer's disease. Next, we're going to go over the characteristics of dementia. First and foremost, it is degenerative. So while the affected areas of the brain are going to differentiate depending on the dementia that the person living with dementia is living with, it's important to understand that this is a brain disorder, meaning that the cells within the brain that are being affected are being broken down and are eventually terminating. The cause of dementia is unknown. However, there are two culprits that have been found in postmortem autopsies, and these are about the only type of culprits that we understand play a role in dementia. So the first is beta amyloid plaques, and these form between brain cells and have toxic effects to their functions. And there are also tangles that are formed when microtubules collapse and prevent the transportation of nutrients between nerve cells, eventually leading to cell death. So again, the cause of this disease is unknown. However, those two culprits are consistently shown during postmortem autopsies. Second, dementia is progressive. So symptoms associated with dementia will gradually worsen over time, unless the person is living with vascular dementia, where it progresses more like a staircase, as previously noted. And however, each experience is individual to the person living with dementia. So we like to say, if you've met somebody living with dementia, you've only met one person living with dementia. What symptoms and individual experiences and when they experience them are going to differ for each individual living with this disease. And lastly, and unfortunately, this disease is irreversible. So this means that once the brain cells die, it cannot be repaired. So there is currently no cure for dementia, and dementia will eventually lead to the end of life. This is because all individuals will eventually lose the ability to perform bodily functions that keep us alive, such as the ability to swallow, breathe, and pump oxygen through the heart. This is because the brain is responsible for sending those messages to our organs in our body. And when the brain becomes damaged, it can no longer tell the other organs how to function properly. So we're going to jump now into the brain and the cerebral hemispheres. And we are going to look at how the brain changes within dementia. So each person, again, is going to experience different symptoms based on what parts of the brain are affected because of what type of dementia they have. It's important to know that this information is meant to give you some examples to help you understand what is happening inside the brain and why we see the behavioral responses that we do with people living with dementia. Our brain is made up of many different parts, and each are responsible for different types of functions within our body. And when the brain is not working properly, we are going to see these changes in abilities that part of brain is responsible for. So first, we're going to look at the frontal lobe. The frontal lobes are large and complex, and they have a wide range of functions. And it is referred to as the management center. They deal with solving problems, setting goals, making decisions, as well as starting, carrying out, and finishing tasks. So this management role is called executive functioning. And we use it to follow a set of steps because we have to maintain attention and hold information in order to use our working memory. The upper and outer parts of the frontal lobe are where we organize and plan actions and learn new tasks that eventually become automatic. And this is termed procedural memory. These areas help us switch between tasks and make us able to do more than one thing at a time. Without them, we would get stuck on a task or not be able to concentrate on one thing for a significant period of time. The upper middle surfaces of the frontal lobes are important for our interest and motivation, and damage here can cause someone to become lethargic and reluctant to do things. It's important to realize that this damage to the brain is not just someone simply being lazy. The area of the underside of the frontal lobe controls our social behavior and lets us perform behaviors that are appropriate for our social settings. And at the back of the frontal lobes is the motor cortex, and this deals with the planning of movements and the control of certain muscles. So if, for example, when we decide to clap our hands or smile or speak, this is the motor cortex sending signals to our body to do these actions. The next lobe we're going to look at is the parietal lobe. They are in the upper rear part of our brain, and they mainly handle information from our senses about space, perception, and size. And we refer to this lobe as the logic center. This lobe allows us to tell our left from our right and where a limb is in front of us. So for example, it helps us when we eat, bring the fork from the plate up to our mouth. Damage to this lobe can lead to clumsiness, and this is most likely common in Alzheimer's disease. The left parietal lobe also plays an important role in reading, writing, and processing numbers. And the right parietal lobe helps us recognize objects as three-dimensional. So it helps us work out where objects are, including moving objects in relation to each other and to ourselves. So these abilities are used, for example, when we pick up an object or when we go to sit down. And damage to the parietal lobe can cause someone problems with finding their way around spaces and being able to move about in their environment. Next, we're going to look at the temporal lobe. This lobe is responsible for dealing with memory, including the recognition of faces and objects. And we term this area the memory center. So our day-to-day memory of personal experiences is known as episodic memory and is very closely linked to our hippocampus, which is inside the temporal lobe. Damage to the hippocampus will result in the loss of memory and the loss of ability to make new long-term memories. The outer part of each temporal lobe is where we store general knowledge, which is a different type of memory known as semantic memory. The left temporal lobe usually deals with facts, the meaning of words, and the names of objects. And this lobe is central to understanding speech and talking. The right temporal lobe usually deals with visual material and is central to recognizing familiar objects and faces. So damage to these areas can result in the loss of recognitions in words, inhibition of talking, difficulty recognizing faces, or the inability to recognize or distinguish objects at all. Next, we're going to look at the occipital lobe. This lobe can be referred to as the vision center, and it is at the back of our brain, and it deals with visual information. When we look at something, the light entering through our eye is converted into electrical signals to the brain, and this is performed in the visual cortex in our occipital lobes. Damage here can cause tunnel vision and blindness, troubles with depth perception, and troubles understanding sensory information. As individuals with dementia progress through this disease, they may experience worsening vision. So typically in early stages, you can consider that a person living with dementia's vision will likely be comparable to if you had a set of scuba goggles on, you can notice that the peripheral vision is starting to become impacted. Once they get into middle stages, this worsens further, and then they you can refer their visuals to looking through a pair of binoculars. And in the late stages, it worsens even more so, and it actually forms an almost monocular point of view. So this is very important to understanding the types, like why they may be startled and why it is important to approach these individuals from the front, because their vision will become more impaired. We're also going to look at the cerebellum and the brainstem. This is at the base of our brain, and it controls bodily functions such as heartbeat and breathing. The nearby cerebellum controls balance and posture. So these are normally things that we consider that we do automatically, but damage to these areas will result in the loss of automatic organ functioning, and this is what leads to the end of life stage. So one way of understanding how dementia affects the brain is to look at the 8 A's of dementia. So the first A that we look at is amnesia, and this means the loss of memory. This is important because everything that we do depends on our ability to remember. As mentioned before, the early stages of this of dementia, the individual will likely experience short-term memory loss, and as the disease progresses, long-term memories will become harder to retrieve. Next is aphasia. This means you lose the ability to use or properly decode language. This includes the ability to speak, understand, read, and write. Although a person may retain the ability to speak for some time, the ability to understand what another person says may be affected. And if you can't understand what is being said to you, this can lead to misunderstandings between you and those around you, and you may find that the person living with dementia withdraws themselves from social interaction. And alternatively, a person may progressively lose their ability to speak or express themselves the way that they used to or the way that they want to, but their comprehension of the communication will actually remain intact. So this creates frustration because they will attempt to communicate with others, but what they're attempting to communicate will not be portrayed properly. And this too may also lead to withdrawal from social interactions. The next A is apraxia, and this means that you lose the ability to tell your body how to carry out purposeful movement. As well, if you have apraxia, you may also have trouble understanding terms such as back, forth, up, and down. When this happens, it's difficult to do any type of activity involving coordination. And apraxia may also affect speech. So this means that the signals from the brain are not correctly sent to the muscles. And as a result, you may have difficulty producing words, or you may say words that you did not intend to say at all. The next A is agnosia, and this means that you can no longer recognize things through your senses. So your sight, sound, taste, touch, and smell all become impacted. You might not be able to sort out what you see or what you hear, and you may have trouble recognizing familiar people. If somebody is experiencing agnosia, then their safety may become a risk because they may confuse objects and what they are intended to use for. So as an example, I know for myself, underneath my bathroom sink, I have my cleaning supplies right next to my Listerine mouthwash. An individual who is experiencing agnosia may pick up the bottle of Windex, seeing the blue liquid, thinking that it is Listerine. Next is apathy. This is a motivation disturbance, not a mood disturbance like depression. So with apathy, they lack motivation and they are unable to get started or initiate speech or activities without encouragement. So this means that the individual will become unconcerned and is not able to take initiative. Then we have anosognosia, and this means that you have lost the ability to recognize that something has changed or that there is something wrong. So you might not understand why you are having cognitive problems, or you may not even realize that you are experiencing problems at all. This is because the part of your brain that helps you reason is damaged. So you do not see the changes in your abilities that others may see. Next, we have altered perception. So this includes both hallucinations and paranoia, as well as misperceptions. So this happens when you misinterpret the information that your senses are giving to you. Another important change is the loss of depth perception and the ability to see in 3 dimensions. So it becomes very difficult to judge how high, deep, long, wide, near, or far objects are from you. So example, lots of homes nowadays, if they have modern fixtures, they tend to have bathrooms that are all white. But if the toilet is the same color as the floor and the wall, they may have difficulty judging when it is close enough to sit down and use the toilet. Lastly, these individuals may experience attention deficits, so meaning they can't keep a focus or maintain attention. They also suffer an inability to shift attention. So this means that their complex attention span is lacking. This is important because paying attention or focusing is needed when trying to accomplish any type of task or communicate with another individual. So with these effects on the brain, you may see individuals starting to show responsive behaviors. So responsive behaviors is a term preferred for individuals living with dementia, representing how their actions, words, and gestures are a response that are often intentional and express something that is important about their personal, social, or physical environment. So we like to use the term responsive behaviors rather than problem behaviors, because as soon as you determine that the behavior is problematic, you are assuming that that individual knows what they are doing and that they are causing a problem. However, as we know, a person living with dementia is experiencing changes in the brain that is affecting their memory, judgment, orientation, mood, and behavior, making these behaviors much more complicated than just being problematic. Responsive behaviors often follow these principles. They're all personal expressions have meaning. Personal expressions communicate meanings, needs, and concerns. To understand their meaning, you must consider the factors influencing their environment, meaning their physical, emotional, and environment elements. When someone exhibits a responsive behavior, you need to reflect on whether it is a problem for the person diagnosed with dementia or if it is a problem for you. Is the solution that you are presenting heightening anxiety? And will changing your expectations of the person living with dementia affect the problem? So it is important to consider the true meaning of these in the moment behaviors. And it's important to consider these following questions when evaluating what happened before, during, and after the event. So 1, Are their physical needs being met? Are they possibly in discomfort or pain? And what changes in their physical condition do you see? 2, intellectual. Have they experienced recent changes in memory? Are they showing impulsive behaviors? Are they struggling with speech or sequence tasks? 3, emotional. Have you noticed increased tearfulness or anxiety? Do they seem lonely? Have they exhibited any new unusual behavior? 4, capabilities. Can they do more than you realize? Do you understand that they may need help? Do they understand that they may need help? 5, environment. Is there too much noise or too large of a crowd? Is the lighting poor, making it hard for them to navigate? Or is there enough stimulation for them? 6, social. Do childhood, early adulthood, or employment experiences offer insight? What do you know about their religion or culture? And 7, actions of others. What are you doing or not doing that may be contributing to this behavior? So we're going to look at a quick example here that's on the slide that may help you understand why these responsive behaviors may be more complex than what we initially understood. So a doctor comes in to see a man living in a long-term care home who is living with dementia. He has been complaining of stomach cramps, and the doctor, who is in a hurry, rushes to the bedside and lifts up his top to examine his stomach. The man hits the doctor and starts screaming for him to leave. This reaction would be a normal response to the feeling of being threatened by someone who to him may have seemed like a stranger trying to do him harm and invaded his personal space. We're going to review some of the most common responsive behaviors that we do see in people living with dementia. These include agitation, wandering and exit seeking, sexual behaviors, sundowning, repetition, anger or aggression, and paranoia. With agitation, a person may be feeling anxious and he or she may become restless, causing a need to move around or pace. They may be upset in certain places or when focused on specific details. Anxiety and agitation may be caused by a number of different circumstances. But ultimately, it's the person who's living with dementia who is biologically experiencing a profound loss in their ability to negotiate new information and new stimulus in their environments. So situations that may lead to agitation could include moving to a new residence or experiencing a new environment. They may be seeing changes in caregiver arrangements. They may be misperceiving threats. They may be dehydrated or experiencing fatigue. And they may be feeling overwhelmed from trying to make sense of this new confusing world. Some tips and tricks for agitation would include creating a safe space, eliminating background noise, and providing an area that the person living with dementia is comfortable in. Ensure that their basic needs are met. Use visual and verbal cues to help with communication. Simplify tasks and routines, providing options so that they are not unlimited and do not cause stress and anxiety to the individual living with dementia. Consider past traumas when evaluating why their agitation may be heightened in certain circumstances. And make sure that when you are bathing or showering this individual, that you do it in a way that still allows the person to have dignity. So for example, we have had clients who cover the person living with dementia. We had them cover them at the top when they are washing the bottom area and then switching vice versa. We have had caregivers who bathe the person living with dementia while wearing a bathing suit. So there are options available to preserve their dignity. All right. The next common responsive behavior is wandering or exit seeking. Wandering is a term that we don't prefer to use because wandering typically makes you think that the person is pacing aimlessly. However, people living with dementia often wander as a result of boredom or searching for something familiar. So they may be attempting to keep themselves busy or returning to an environment that they think that they need to go to. So for example, if an individual used to leave for work every morning at 7 a.m., you may find that wandering occurs at this time because they still have that internal clock where they think that they need to get to their job. So for example, that would be why they have the desire to fulfill former obligations. They may also be trying to provide themselves basic needs, such as finding the washroom or getting themselves something to eat. Strategies for wandering and exit seeking would be providing them with person-centered activation, encouraging movement and exercise to reduce their anxiety, maintain regular routines, remove visual reminders such as coats, hats, boots, purses, so that they don't see those items and have the urge to exit. You can also involve the person in productive activities, ask them for help in basic chores such as folding laundry to keep them occupied. Help the person connect with familiar items and objects such as photos or personal items to keep them centered in that space. You can reassure the person where they are, and you can accommodate wandering. This ability to get up and move may be the last independent skill that the person living with dementia has. So next, we're going to go over sexual behavior. So sexual inappropriate behavior, such as genital touching, undressing in public, lewd remarks, unreasonable sexual demands, or even sexually aggressive behavior may occur as dementia progresses. It's important to remember that this behavior is caused by the disease. However, if an individual is presenting this type of responsive behavior, they may be trying to express a different unrelated need. So for example, if a man unzips his zipper, or if a woman may raise her skirt, perhaps they are looking for a washroom. The behavior could be a request for attention. Perhaps they are lonely or bored, or maybe they misinterpreted the touch or an approach of a caregiver or a family member. If the sexual expression is indeed a need to express the sexual desire, it's best to probably just give them some privacy to satisfy their needs. They are still human beings, and it is important not to judge or scold them for this type of behavior. If the sexual satisfaction is not possible, perhaps you can try to distract them with another activity that they will enjoy. If you are the object of these, if you are the object of the sexual desire, don't get upset, try and remain calm. Keep your sense of humor about it and try to distract them with another non-sexual activity. And if there is another person who the sexual advances are made towards, try to remove the person living with dementia from the situation and then explain the circumstances to the other person. You may also want to avoid approaching the person in the way that may be misunderstood, such as sitting hip to hip or putting your arm around their waist, touching their knee, any type of action that may be misinterpreted as a sexual advance. Next, we're going to look at the term sundowning. So this is when people become agitated, specifically in the late afternoon or evening, and it is known as sundowning. They may become suspicious, upset, or disoriented, see or hear things that are not there, and believe things that are not true. Oftentimes, individuals experiencing this responsive behavior may mix up night and day. They may express the want to go home. They may become disoriented, and they may be expressing exhaustion. Strategies for dealing with sundowning would be to encourage shorter naps during the day or discourage napping at all. Ask family members or your recreational staff to schedule calming activities when these types of agitation occur. Work with caregivers and staff to restrict sweets and avoid caffeine around the evening. Provide adequate lighting to help the person living with dementia to identify objects and people. As well, you can provide this type of adequate lighting during the evenings, specifically in the winter months when it gets darker earlier. And the amount of lighting may help them realize that it is not yet time to go to sleep. You can provide items of comfort like their favorite pillow or blanket. You can plan and encourage activities during the day that may result in them needing more rest in the evening. And you can provide reassurance as a distraction. There's also the common responsive behavior as repetition. Repetitive behaviors, such as asking the same question over and over or constant hand rubbing, are often due to memory loss, and they may reflect feelings of insecurity, loneliness, or loss. In some instances, it could also indicate a physical need is not being met. So for instance, if your loved one or the person living with dementia is constantly pulling at their clothing or fidgeting with buttons, they may need to use the restroom. Strategies for dealing with repetitive responsive behaviors would be, you can use distraction. So involve the person in an activity that they enjoy, such as going for a walk or offering a snack. Consider the question that they are asking and respond to the emotion being expressed. So avoid telling the person that they have already asked this question, as it may be more upsetting and cause further anxiety for the individual living with dementia. Speak calmly when answering the question, even if you have already answered it numerous times. The person living with dementia will not recognize that they have continuously asked their question, and your frustration will only cause further anxiety for them. You can help cue their memory by posting calendars, notices of mealtime, or signs to help them orientate themselves with the environment, such as signs on cupboard doors referencing what is inside that cupboard, signs on the bathroom door indicating that that is the washroom, things like that. For repetitive actions, such as tapping, try giving them something that they can occupy their hands with. So often some string or a ball will help them with this type of fidgeting. And you can fit the repetitive action into the normal household chores. So for example, if the person may have enjoyed cleaning earlier in their lives, you can give them a rag and allow them to continuously dust the area, as this will not provide harm to them or to you as the care provider. Lastly, we're going to go over anger or aggression as a responsive behavior. So the person living with dementia may become angry for reasons that are not immediately obvious. This could be in part to their sense of grief and loss as they are experiencing their world slowly becoming unfamiliar. It could be due to fear of a situation or a person that they find threatening. And as the disease progresses, the person living with dementia is going to find it increasingly difficult to express their emotions in appropriate ways. So aggression may be physical or verbal, and it may happen quite suddenly without an apparent reason. So strategies for dealing with aggression would be to watch for a sudden increase in movement that may indicate anxiety. Respond in a supportive manner and reassure in a gentle voice. Reduce noise and increase lighting to provide a more inclusive environment. Ensure that the staff maintains a consistent routine when coming to work with the person living with dementia. Speak slowly and try to reiterate what you are trying to say in different terms if they are not understanding what you are saying the first time around. You can use distraction techniques. Make sure that you approach the individual slowly and from the front at their eye level so that they do not become surprised by your presence. And avoid arguing or expressing anger or irritation, both verbally and non-verbally. You are allowed to leave the room for a time out if this aggression is getting too much for you to handle as a care provider. It is important, though, to remember that this is the disease providing this type of responsive behavior and not actually the person themselves. We do have one more, and that is paranoia. When someone hallucinates, so they see or hear something that no one else does, if it is not upsetting, you do not have to intervene with it. Further, there are delusions, and this is beliefs contrary to facts. So they typically remain persistent despite all evidence to the contrary. So for example, somebody living in a long-term care home may have the delusion that a nurse working with them has stolen all of their money, despite the fact that this is not true. However, it is important to not disengage what they are saying. They may actually be a victim, so you have to take that into consideration as well. Strategies that you can use for dealing with paranoia include meeting with the physician to review medications, schedule hearing and vision tests, as their paranoia may be coming from their type of sensory. You may also seek medical evaluation for illnesses, infections, such as urinary tract infections that is known to cause delirium. If the person living with dementia becomes suspicious, you can help them look for lost items and remind the person where valuable items are stored. So don't scold them for losing items, but instead you can keep spare items available if it's possible to do so. Increase lighting in the room to minimize shadows. Don't directly disagree with a false idea, as this may make them more agitated. All right. So just to review, these are the key tools that you can use when you want to deal with a common responsive behavior that may be present with the person living with dementia. So letting them know that they are safe and provide comfort, validate their emotions, treat them with dignity and respect. Get to know the person's likes and dislikes. Always approach from the front, making eye contact. Remind yourself it's a disease and they cannot control the changes that they are experiencing. Provide them with comfort and moments of happiness, and always refer to their personhood. Getting to know the person living with dementia is going to help you connect with the behaviors that they are presenting in the current. And further, we're just going to review the problem-solving model for coming to understand why the person may be presenting this responsive behavior. So again, you have to consider their physical health, their intellectual capacity and behavior, their emotional health, and their spiritual and cultural needs, their capabilities and their functional levels, their environment, and their social, cultural, and life story. So this framework can help you create and help you screen and assess the behaviors in an efficient but comprehensive way. And it will help you understand the causes behind the behavior and draw a more accurate and effective intervention plan for dealing with responsive behaviors being expressed by a person living with dementia. So I want to thank you all. There are some additional training for the brain and behavior. If you are interested, you can contact me and I can forward you an education request form, and you can participate in one of our other education presentations. I know that this was a lot of information to hear at once, and I respect you all for being so patient with me, and I will open the floor now to any questions that anyone may have.
So people can feel free to use the Q&A, or if you want to raise your hand, Kelsey can unmute you and you can have a conversation with Ava. Definitely was a lot of information to take in, but it was really great, and your examples were amazing. So we just have Sam in the chat said, thank you, Ava, another great presentation.
For anybody that may be wanting more examples to help them understand what they have just learned here today, feel free to reach out. I didn't provide as many examples as what we usually do, just because I wanted to be respectful of everyone's time. But if they are looking for further examples, I'd be happy to share those with them.
That sounds great. All right, well, I'm not hearing anything. I think everyone's just taking all the information in. So with that, I think we'll end the session, and just thank you to everyone who participated and came and listened. Oh, Cord said, thank you, Ava, for a great presentation. You are certainly very knowledgeable in this area.
Thank you.
Great feedback.
Okay, well, I appreciate everybody for coming out and listening to me today.